Good morning. My name is Paul Leong. Thank you for that very nice introduction. I am a facial plastic surgeon practicing in Pittsburgh, Pennsylvania in the United States. It's a tremendous honor to be able to come to Taiwan. I'd like to thank Dr. Chan, my friend. Dr. Chan and I are of the belief that God wants us to work together, because I keep bumping into him in places that I don't expect. But in any case, it's a tremendous honor to be here in Taiwan to talk about facelifting, and I've enjoyed the meeting tremendously, and I've made many new friends, so thank you very much. Next slide. So in terms of disclosure, I don't receive any financial support from anybody. Next slide. So presentation contents. I'm going to talk to you today about what I refer to as the high Smas and low platysma facelift technique. I'm going to review some of the rationale and advantages of the high Smas approach. I'll also talk about some of the disadvantages. Any surgical technique you consider, just like anything in life, there are certain pros and cons. I'll try to be objective and cover those as well as I can. A technique, I'll use a series of still pictures, but also videos to demonstrate the technique. I'll also talk a little bit, just for a minute or two, about the low platysma contribution to this, which is focused, of course, on the lower and central neck. I'll give some examples of my own patients, and then we'll try to draw some conclusions together. So in terms of, number one, the development of the high Smas technique, the history of the high Smas technique actually goes back about 20 or 30 years. One thing I want to make very clear is that what I'm presenting today is, this is sort of an amalgamation of techniques. I set out to sort of learn about the best facelifting technique I could find in the world, and I've been very fortunate to receive training, but then also further exposure during my practice to some wonderful people. There's no single thing that I'm going to present to you that I personally have developed. I think most of us in surgery recognize that we're all standing on the shoulders of giants, and so I'll identify a few of those by name as I go through the presentation. But in terms of the development of and thinking about high Smas, if this is a topic that's going to be of interest to you, there's one sort of given that you need to sort of accept, and that is that dissecting in a facelift beneath the Smas, in a sub-Smas, you may call it a deep plane approach, is superior than the other methods of suspending the Smas in a facelift technique. And I'm the first to concede that clear and objective data. In the United States, I've made some modest contributions to what we refer to as the evidence base supporting facial plastic surgery. And you can parse the literature all you like. There's no definitive evidence that doing a deep plane or dissecting under the Smas is superior than doing a plication or an imbrication facelift. These studies, as you know, are very difficult to do. But as a starting point of this discussion, compared to, as I've shown here, a skin-only or a plication, imbrication, or a Smasectomy approach, if you accept the given that, geez, I'm going to go ahead and dissect under the Smas and reposition the Smas anatomically like that, then it begs several additional questions that lead to the development of the high Smas technique. Next slide, please. So, if one were to accept the superiority of a sub-Smas or deep plane approach to facelifting, in spite of the lack of objective evidence that that is definitively superior, then you need to ask the questions: where should I incise the Smas? To what extent should I undermine the Smas? Along what vectors should I mobilize the Smas relative to the skin? Do I do so in the same vector or in distinct vectors? Answering these questions encompasses a lot of the development of this approach over the last several decades. Next slide. And so let's just assume for a second that we here in this room have decided, for the sake of argument, that yep, we believe that dissecting under the Smas is the way to go, doing a deep plane approach, you could call it. So if we see here, see if I can use this pointer. This would be, what one might refer to as one variant on a classical place in which you could incise the Smas, here with a component in front of the auricle, and then a little bit of a jigger forward in a horizontal fashion, but definitively inferior to the level of the zygomatic arch. This is a commendable approach because the frontal branch, which was mentioned in the last presentation, the temporal branch of the facial nerve, is still largely out of harm's way at this location. People understandably are a little bit more concerned about dissecting horizontally superior to that, and we'll cover that. Next slide. Here's another perfectly acceptable, time-tested location to dissect through the Smas right here. This you could say is even more conservative because you're out of the path of the frontal branch, and then you can elevate the Smas here. Just as in the previous picture, you can see this circle, this sort of zone of influence, you could call it, demonstrates, from a realistic standpoint, where you're going to be able to make your maximum clinical, your maximum cosmetic impact if you use these more traditional incisions to access the Smas. And so you can see this is mostly about improving the neck, the submentum, maybe not so much in the lower neck, but also in the jowl area. And that's pretty good, because in my marketplace, and I suspect in yours, a lot of men and women, they're concerned about the jowls and they're concerned about their neck. And if you can improve that and do so effectively, I think you've done quite a good job. Next slide, please. So the low Smas, in summary, is elevated. The Smas incision is beneath the zygomatic arch. Disadvantages, you could argue, would be that there is limited impact on the midface in the infraorbital region, often mandating separate midfacial procedures of the kind that we just heard about in the previous presentation. Advantages over what I'm about to present to you, you could say that it's quicker. I would agree that it's quicker if you dissect that because there's lesser amounts of dissection. Is it safer? Some people would be concerned about that frontal branch. I have done a very large number of these procedures, and I'll review a piece of literature submitted to the literature by Dr. Fritz Barton in Dallas. I have never had even a temporary, even a slight difficulty with the frontal branch with the high Smas approach. Next slide, please. And so what is the high Smas? Well, it's really pretty simple. Okay, the idea is that you extend this vertical component higher in front of the hair tuft, and then you come horizontally at a higher level. It doesn't have to be quite this high, but it's along the apex of the zygomatic arch, or perhaps a little bit higher than that. And quite rationally, the zone of influence, you could say, is larger. Here you can go ahead and impact the mid-face, the mid-cheek, and the infraorbital region more effectively, while simultaneously improving the areas impacted by the more traditional incisions that I just described. And this all has to do with one's aesthetic. I think it's conceptually and aesthetically appealing to en masse, in a single contiguous flap, rejuvenate this whole area, as opposed to doing so piecemeal with different procedures. Next slide, please. And this is simply replicating this, showing the position of the zygomatic arch. Next slide, please. Please. Okay, so in summary, the high Smas incision is elevated along the superior border or directly over the zygomatic arch. The advantages: improved upper cheek contour, enhanced fill of the infraorbital region, increased support for the lower eyelid. If you're doing a separate lower eyelid procedure, we all have little concerns about ectropion and what have you. You can give yourself some insurance against that. And potentially, and again, speaking to evidence, I wish I could tell you there's evidence suggesting there's superior correction of the nasolabial fold. I think I'd have difficulty pointing that out to you, but subjectively, I think that's the case. Disadvantages, again, questions of safety. What about that frontal branch? We're about to talk about that. I would say I think it is every bit as safe if you know what you're dissecting through, just like any form of surgery. Does it require more time? It sure does. It requires more time. And so I think for many surgeons, as I've presented this and talked about this in the United States, in their mind, very often they'll say, listen, I think this is a somewhat better result, but it's weighed. We live in a very practical world, and it's weighed against the additional time and effort to do it. I would suggest that your patient appreciates the additional 90 minutes in the operating room to do this if you are convinced that it is good. So what about that frontal branch? Next slide, please. And so this is this piece of literature. One of these gentlemen, Dr. Fritz Barton, he's got a very nice book. It's being sold right up the stairs, talking about specifically the safety of the frontal branch. We saw some very nice videos in the previous presentations. I won't get too deeply into this, but the point is that the frontal branch is really quite adherent to the zygomatic arch. And I'll show you in the videos how we elevate the Smas over the zygomatic arch and can incise it safely. Next slide, please. Now then, a little bit more history. I've mentioned Dr. Barden, who practices in Dallas, Texas, several times. The two people who are most closely affiliated with the origins of this procedure, and I've been very fortunate to be able to spend some time with both of them. Dr. Barden is in Dallas, Texas. There is a distinction between him and one of his colleagues, Dr. Bruce Cannell. Dr. Cannell has been enormously influential on me and on many others around the world. And again, I was fortunate to do some procedures with him and spend some time with him in his debt for that. So the distinction between these two gentlemen and how they think about the high Smas facelift, though they both more or less refer to it as a high Smas facelift, is that Dr. Barton, when he incises the Smas, leaves the Smas composite, or as Dr. Skoog of Sweden many decades ago talked about, it is a continuous, it is an en bloc, the skin, the subcutaneous tissue, and the Smas. The advantages of this is that it is quicker. You're not dissecting two planes, and also that the Smas flap is hardier because, of course, it's thicker. It's connected to the skin. The disadvantage of this, you could say, is that by necessity you have to mobilize the Smas and the skin in an identical vector. Dr. Cannell prefers, as I do, a lamellar dissection in which you separate the skin, and this will be very clearly shown on the videos, from the Smas, and therefore you are spending, again, more time. You have to be very careful about elevating the Smas, because if you do it in a hurried way, or if you take up some of the Smas when you lift the skin flap, you're going to sort of buttonhole and be pulling up a piece of Swiss cheese as opposed to a continuous flap. The huge benefit is that you're able to mobilize the Smas in a distinct vector. When I do this procedure, the Smas is not in a purely vertical orientation, but it's closer to a vertical orientation, whereas the skin is not in a completely horizontal orientation, obviously, but it is more horizontal than the Smas. My patients in the United States like this, I think, because I feel that it results in a particularly natural appearance. My patients fear two things about facelifting. Number one, something dreadful will happen in the operating room and there'll be some difficulty. We reassure them that that doesn't happen very often. Number two would be that they'll look funny, that they'll look like they've had a facelift, they'll look artificial in some sense. We're extraordinarily focused on this second point. We want a natural appearance, and this delamination of the flap we think is fundamental to doing that. Next slide. Okay, so now some pictures and some videos. I'll tell you when to click on the videos. Thank you. So this is the incision. This is sort of a fairly basic, but there's some technical points. We always go behind the tragus. This is not technically retrotragal. It's on the posterior aspect of the tragus. It's very important, we think, to have some very tight sort of what we call bird's beak. I like to make this very sharp here and very sharp here above the auricle. It allows us to helps us obscure this incision very, very well. Next slide, please. The postauricular incision, this limb here, you can see it's a decent incision. It's always right along or just behind the hairline. We never move the hairline, and we tuck it back here. We find that if I simply close the incision without any tension and place it in the correct position, and that the incision heals extremely well. It's important for us that our patients can wear their hair in a ponytail or in a baseball cap or something like that and feel perfectly comfortable. And I'll show you some pictures of these postauricular incisions later on. Next slide, please. And so we can play the video now, please. Start button over here. Okay, and so this is most patients, not all, but most. We begin with a submental incision, and we do, a la Dr. Feldman, a corset platysmoplasty. And of course, we've opened the skin pocket in that area. Next slide, please. Okay, this is a critical part of the procedure. It might seem mundane, but the next step is, of course, to elevate the skin flap in the superior portion of the face. And so you can see I'm using this transillumination technique in which the overhead light is behind. Most of the lights in the room are off, and I'm looking for the light and as I snip each piece of tissue. I do not tend to, sort of lay the flap perpendicular to the face and so-called, as Dr. Knau would say, just push and scissors. When you do this, if you do this. I think many surgeons, including me up to relatively a few years ago, felt I'm elevating this skin flap in a rather precise plane. Well, just harsh experience showed me that when I did that, my Smas flap was friable. But when I elevate the skin flap this way, it's not reproducibly. So if we go to the next slide, and we can play this video, please. There'll be about a dozen videos, so we'll. Okay, good. So you can see here, this is trans-illumination, and we're snipping. And you can see my assistant is pulling up the skin and leaning it slightly towards me. My left hand is distracting the skin a little bit anteriorly. And the next video will show this under a little bit greater magnification. Next slide, please. Next slide, please. Good. And we'll go ahead and play the video. Okay, so one more time, and this is under a little bit greater magnification. It's a fairly simple point, but there I am. And you can see every time you snip, you can see the light. That picture's sort of adequate. You can see the light further and further through the flap. And so this is something I thought this was rather persnickety when I first saw it, and takes more time, but I feel it's absolutely vital to maintaining the thickness of the Smas flap in that critical area here in the upper portion of the face. Next slide, please. Okay, so play the video, please. Okay, and so this is nothing special here. We're doing a long cervical flap where I'm, of course, joining the skin flap that you've just seen me elevate to the one in the submental region. So we've elevated a good deal of skin. Next slide, please. Good. And so here we have a patient. Interestingly, I was reviewing this presentation this morning. This is actually a Korean-American patient living in Pittsburgh, Pennsylvania. And you can see I don't routinely do this, but but for the purpose of this presentation, I've marked with ink the location of the Smas incision. So you can see this is rather superior along sort of the apex of the zygomatic arch. And down here, what this doesn't show is sort of the so-called low platysma, the incision down into the platysma. Next slide, please. Wonderful. And I think that's a video. We can play that. This is the important zygomatic. So this is dissecting immediately on top of the zygomatic arch, or perhaps a bit superior to it. You can see I'm elevating. The next video will show this under greater magnification. But you can see I've got some Alice clamps, and I'm elevating the Smas to give us a little bit of tenting. And now please go to the next slide. Okay, and play that video. And so this is under greater magnification. No. Okay, and so you can see spreading, elevating, and now cutting. And you won't damage the frontal branch. Okay, next slide, please. Okay, and so we'll play that video too, please. The box is always in the same spot. You can bump. Okay, good. So you can see I'm elevating now in the superior posterior corner. This is where we start the Smas elevation. So I'm dissecting, and you can see the skin is up, the skin is here, this is the Smas flap coming up. So you can see this patient actually, this is a different patient. She's more than 60 years old, thin Caucasian woman who generally you would consider would have a lesser Smas flap than, say, a woman from Northeast Asia. And you can see, next slide, please. Great, and we'll play that video. Wonderful. And so you can see I've proceeded. We're continuing to raise this, I think what would appear to me and to you as a fairly robust Smas flap contiguously. Okay, wonderful. Next slide. Okay, and that's just a still picture. No, go to the previous slide. That's a still picture, and shows, sort of that where we're at in the procedure now. Next slide, please. Okay, go ahead and play the video, please. Okay, that's the picture. So I don't think there's a video there. I'm sorry. Go to the next slide, please. My fault. Okay. Now we can go ahead and play the video. All right. So this shows elevation in the inferior aspect. Again, nothing very special. I'm under, you can see the skin is up, and I'm under the Smas, and I'm dissecting into the cervical area. Next slide, please. Okay, and I believe that's the video. No, it's not. So I'm sorry. So this picture shows sort of a little trick, a little gimmick. When you're dissecting down into the neck, and of course you're naturally concerned about the cervical branch or the marginal mandibular branch, there's a good area, there's a good surface area of the Smas that can be elevated by using sort of blunt dissection. You can buy an instrument, it costs a little bit of money, but I find a long nasal speculum works perfectly well. If you go to the next slide, there's a video that shows this. And play the video, please. Perfect. So you can see here, nothing too jazzy. I'm using this blunt instrument, and I'm elevating, and you can stick that quite a ways in and elevate the Smas, and there's no sharp element to the dissection, so you can feel comfortable if you feel you're close to some neural structures. Next slide, please. Okay, and so we'll play this video. And so this shows go ahead and play this video. Thank you. Okay, so this shows the contiguous flap elevated. You can see there, here's the ear over here, here's the superior aspect. So this is a continuous, robust Smas flap, and that is what is going to be used to elevate the face. Next slide, please. Okay, so this is before any suspension. This picture is useful because it shows this inner circle. This conforms roughly to the area that the Smas is elevated. So the Smas dissection continues over this circle here. And of course, patients, not patients so much, but other surgeons ask, how far should I dissect under the Smas? The endpoint is variable from patient to patient. It depends upon the unique location of their retaining ligaments. So whether it's the mandibular or the parotidomastoteric or the zygomatic ligaments, the critical endpoint is clinical, which means you continue to release these ligaments until you feel them lyse, and then you're able to mobilize the face effectively, and then you're done. It's not a set endpoint. It depends upon your dissection. We've not done any suspension. The larger circle represents the skin elevation. The smaller circle represents the Smas elevation. Next slide, please. Okay, that's again just a picture. This is the skin layer, a la Dr. Cannell. It's delaminated, so there's a separate skin layer and there's a separate Smas layer. Next slide, please. Thank you. And this one shows it down in its anatomic position. The previous slide showed it up. Next slide, please. All right. This is not a video. What this shows, after you've elevated the Smas, we take the posterior aspect of the Smas and we trim it and we translocate the Smas behind the ear. This is an old trick. Lots of people do this. And this helps to define the cervical aspect of the end result. Next slide, please. And this is after the suspension. I've not shown you too many of the suture placements, but it's fairly routine. These are horizontal mattress 5/0 PDS sutures. It's not wrong to use marceline or permanent sutures. There's subtle trade-offs in terms of extrusion. Some people who I respect very much use marceline sutures. I use 3/0 PDS sutures. And so you can see there's quite a bit of overlap of skin. This is after the suspension suture has been placed. And again, the skin is mobilized in a somewhat more horizontal vector, whereas the Smas, underlying this, if I were to be able to lift this up, is in a somewhat more vertical orientation. Next slide, please. Okay, certain further details. I apologize, we only have 20 minutes to do this presentation, so there's other very relevant details in terms of exactly the ligamentous release that I talked about. Exactly how far should you release the skin from the underlying Smas layer. It's not willy-nilly, it's not meant to be just you dissect to the nasolabial fold. There's some technical, we do less than that. I do less than that. And there are reasons to do that. In terms of the platysmal transection, not in all patients. I'd say in about 30 or 40% of patients with fairly dense platysmal banding, we do a full transection of the platysma. It's very important to do it low in the neck. That's a relevant detail in this procedure that I'm not really getting too much into. And finally, in terms of your cervical end result. In patients who have ptotic submandibular glands, and I'd say there are many excellent surgeons in the United States that don't go after this, and I'm respectful of that decision. It depends upon your comfort level. But if there are ptotic submandibular glands, portions of these submandibular glands can be removed because all of the ptosis in the neck is sort of cloaking. As the submandibular glands have come down, so has the soft tissue around it, so the patient doesn't see it. And then post-operatively, you do this lovely, you pull this bed sheet nice and tight, and you've got a lovely neck, but then they're seeing the submandibular glands that they never saw when they were younger. And then they, unless you discuss that in detail preoperatively, they're less happy. Other details, bulky anterior belly of the digastric muscle. These are things that are very important on your physical exam before the procedure. Next slide, please. Okay. So now just a few minutes about this other aspect. We've talked about the high Smas component here, but what about this so-called low platysma? The point is that, as I showed in that picture that didn't actually show the dissection, the incision through the Smas, it's a fairly straightforward point, and I'm hardly unique in employing this, but if you carefully dissect now inferior, perhaps 3 or 4 centimeters inferior to the angle of the mandible, it makes sense. You're able to elevate this tissue posteriorly, and I think get a very clean and attractive appearance in the lower neck and in the medial neck. Next slide, please. And so advantages and disadvantages of this low platysma component has the same improvement when paired to the high Smas approach as the mid-face and the infraorbital areas. However, there's enhanced, I think, a cosmetic outcome in the cervix, in the neck, excuse me. Disadvantages, it requires more time, and you need to be careful, okay, in terms of the cervical branch and the marginal mandibular branch. It's extremely important to dissect on the immediate inferior surface of the platysma to avoid injuries to those nerves. Next slide, please. Okay, so some results. This is 17 months status post Smas, high Smas, low platysma facelift. With this patient also had some fat transfer. And what we're focused on here is that there's a good result in the neck and the jowls, but the mid-face, I think, is improved. Next slide, please. Next slide. Running a bit low on time, so we're going to move a bit quickly. Again, 13-month status post high Smas, low platysma facelift. Our patients, above all else, they want to appear natural. If they look surprised, if they look taut, it's bad news. And so again, I pride myself on patients. I'd prefer to give up 5% of the result, but maintain the patient's natural appearance. Next slide. We often take this picture with the chin down. It forces the surgeon to look realistically at all of your results. Next slide. Next slide. This is a lady, 11-month status post high Smas, low platysma facelift. I'm sorry, not quite a 1-year result here. And so this is improvement in the jowls and the neck. Because I'm blocking her identity, you don't see all of the infraorbital area. Next slide. Next slide. Next slide. Next lady had the absolutely full standard incision through here. This is the first bird's beak up here, the second one here, along here, and right back here. And I think it's very, it'd be hard to see this lady's incision. Next slide. Okay, so conclusions. The low cheek Smas flap, shall we call it, the traditional Smas flap, elevated below the zygomatic arch, does not impact to the same degree the midface and the infraorbital region. Planting the flap a little bit higher along the superior border of the zygomatic arch allows a simultaneous lift of the jawline of the cheek and the midface with a single unified flap, and is compelling, I believe. Incorporating an extended platysmal elevation and suspension permits a more comprehensive and durable rejuvenation of the medial and lower neck. Next slide. Last slide. So, is the argument, like any surgeon, you know, you look at a technique like this or all the other fabulous techniques you've heard at this meeting, is pursuing the high Smas low platys approach to facelifting compelling? Does it merit the additional effort and additional risk? What I tell you is that I think if you understand the anatomy well, just like any of the procedures we've heard about, I think it's absolutely safe. It's a routine surgery. I would say the trade-off for the surgeon is that everybody I know who's sort of taken some enthusiasm to this approach, it takes a little bit longer in the operating room. Not tremendously longer, but raising that skin flap, you have to be a little bit fastidious. and then there's simply a somewhat greater degree of dissection. And so that's a decision that each of us has to make personally. But I appreciate your attention very much. If there are, I think there's just a little bit of time. Maybe if we have any questions, I'm more than welcome to answer them. All right. Thank you so much.